Thank you for inviting me to talk at ASIPA didactic lecture. So my talk go to talk modern imaging for epilepsy, a practical guide. I'm nothing to be disclosure. MI scan is very important to play the central role in management and evaluation of people with epilepsy. In patients with the newly diagnosed epilepsy, present of the epileptic lesion on MI scan significantly increase the chance of the medication resistance. In patients being considered for epilepsy surgery, present of the epileptogenic lesion provide the surgical target and increase the chance of the post-surgical freedom. MRI scan should be obtained early in the clinical course and using the proper protocol, using the harmonize the neuroimaging for epilepsy structural sequence. We call the harness MRI scan protocol that's proposed by LLE Imaging Task Force. And also needs to carefully review by the trained experts who have available clinical data and investigation results. So this the protocol of the harness protocol. The first we use the epilepsy with the 3D MRI scan T1 with imaging and the sequence by the gradient echo and the voxel size about 1 millimeter. This one to best to evaluate about anatomy and morphology, the volume thickness, sulcus gyra shape, and the gray white matter interface integrity. The next sequence that we use a 3D acquisition with a high resolution. This one very simple for us to go allow with this different view with the sagittal, coronal, and the transaxial view. This one very simple. We can go to the target by the clicking on the point that we're looking, and we show up at the coronal, transaxial, and sagittal. But have to be really careful about the partial volume effect by review this acquisition. It's syndrome specific protocol, not necessarily. So one volume can be replaced with the multiple 3D acquisition. But to avoid the volume effect, you might be have a thin slide cutting with the 1 millimeter. The next protocol, we use the flare. This is a sequence tri turbo spin echo. The voxel size about 1 meter as well. So this one to best evaluate about the signal intensity. This one very sensitive to detect about the focal cortical dysplasia, hippocampal sclerosis, tumor, hematoma, or maybe the gray scar. But you have to be aware that this flare technique is not sensitive in neonate and the children less than 2 years old because due to the incomplete myelination. The next one we call the 2D MRI scan with looking about the particular to the area of the mesostemporal area. This one we need to get the imaging perpendicular to the hippocampal long axis. The sequence type is the turbo spin echo. The voxel size about 0.4 plus 2. No interslide gap. So this imaging technique to evaluate about the hippocampal internal architecture, amygdala, and the parahippocampal gyrus. And the last protocol we call the optional sequence. So this, for example, like the gadolinium enhanced 3D T1. This one to detect about the tumor, infection processes, or maybe vascular malformation. Another one we call the weight imaging on T2. This one sensitive to detect about the blood product or maybe calcification. For example, to assess about the carcinoma. So when we got the MRI scan done, we need to see whether MRI scan show the lesion or no lesion. If there's no lesion, you have to check about the quality of the MRI scan. You have to detect whether MRI scan have a lot of artifact, not a good quality. Whether they have doing the proper protocol with the harness protocol, and also after that, if you still got the no lesion, you might review correlation with the other data. For example, correlate with the clinical seismology, video EEG data, PET scan, SPECT, and MEG. And also have been used the advanced technique for processing neuroimaging. For example, like to do the coexistence, subtraction, or maybe the with the algorithm with the high technique to identify whether have a lesion or no lesion. If the patient have a lesion, and then you can go to with the surgical hypothesis forming, and also have to assess about eloquent area whether you can do the surgery. If there's no overlap with the eloquent cortex, you can go straight for the surgical planning But if the lesion potential overlap with the eloquent cortex, you need another advanced imaging to assess about the functional area before to the resection. For example, like the do a fMRI scan or maybe the DTI to assess about the functional cortex. Very common the epileptic pathology that can be found when we do MRI scan. For example, like the mesial temporal sclerosis. This is assessed by the looking about the T2 weight imaging and the flare technique. You see the loss of the volume of the hippocampus, and also internal articulator have been abnormal. On the T2 weight imaging, and also on the flare, you see the increased signal on the flare technique. Another common epileptic pathology we call the cortical dysplasia, particularly the focal cortical dysplasia. This one is sometimes very subtle and masked by the complex neocortical convexity. So the detection may be much more difficult when the non-invasive clinical data, for example, like the skull EEG or maybe SOVG is non-localizing. So the example of the focal cortical dysplasia, you see very subtle lesion on the flare, you might be seeing increased a little bit signal, and you might be seeing the tangential side on the good quality MRI scan. When the MRI became negative, it can be up to 50% of the case with the drug-resistant epilepsy, evaluated for the surgery there on the MRI scan. So additional MRI scan depend on the pathway of the review the scan in many instances. Initial MRI scan could be interpreted as the negative. However, about the second focus review again, it might be because we might be get some additional information from localizing data from other neuroimaging. You might be found review the lesion finally. So in MRI negative case, one should first determine if the MRI scan that we have looking for is acquired properly. So using the harness MRI epilepsy protocol that's proposed by the ILE Neuroimaging Task Force. In the presence of the artifact related to the subject motion, you might be repeat another MRI scan again, preferable with the 3 Tesla MRI scan with the proper protocol. Sedation may also be required for the patient who have anxious or claustrophobia or in the pediatric case. So one should further analyze it with the review of MRI scan if we consider that do not see any lesion. For example, doing about the multimodal imaging data analysis. So example for you might be found identify the subtle lesion by doing the another imaging, for example, like the PET scan or the SPECT. And then finally, after you collision with together, you might be found a small lesion like the cortical dysplasia, small bottom of the sulcus dysplasia, or maybe small lesion like the encephalocele hypothalamic hamartoma, or maybe subtle double cortex can be maybe overlooked at the first time, but if you do think about with the correlation with other imaging data, you might be identify this lesion. Also, the MRI post-processing is very helpful to characterize about epileptic tissue, particularly the focal cortical dysplasia. Some of this post-processing algorithm includes the voxel-based morphometry. We call the VBM imaging. You might be identify the subtle lesion on the VBM imaging. Or even though the collinear reformat of the cortex, you can be looking about the surface, can see more clearly with the lesion. For example, like this in the insular cortex, when you do collinear reformatting, you might see the abnormal gyrus clearly. So post-processing algorithm generally operate on the 3D T1 weight volumetric data with the whole-brain correlate using the statistical map to direct about the reader attention to potential abnormality. I'll go to next with the fMRI scan. The fMRI scan, we use the task-based functional MRI scan used in the context of the physical workup. It determines confirm the language and hemispheric dominant, often in the setting of the temporal lobe resection in the dominant hemisphere. So due to this non-invasive, it's a safer, provide more precise localization and more cost-effective than the WADA test, particularly in the patient with strong left lateral language. The example of the language fMRI scan, so and you see the activated on the left inferior frontal and the left posterior superior temporal. That one is more significant on the left rather than on the right side. So also the fMRI scan had been approved as the guideline of the American Academy of Neurology user for using as the assess about the verbal memory or language encoding should be considered by predicting post-operative verbal memory outcome. This recommend at the level B recommendation. The example of the verbal fluency of the MRI scan on the fMRI scan. So MRI scan using the non-verbal memory encoding may be also considered for predicting about the post-operative visual spatial memory outcome as well at the level C recommendation. This example of the location of the non-verbal generation in patient with the temporal epilepsy with the hippocampal sclerosis. Also, the functional MRI scan can also be used to mapping of the primary cortex, somatosensory cortex, and also the visual cortex. In particular useful when epileptic pathology such as the tumor, gliosis, or FCD is very close to the eloquent cortex. Distortion of the local anatomy mark predicting of the eloquent cortex could be difficult, and the functional reorganization could be unpredictable, and the presence of this lesion. Also, another technique we call the fMRI scan with together with EEG, we call EEG fMRI scan, have been increasing use to map pattern of the brain activation associated with the focal intellectual epileptic discharge, deviation on the EEG, and go to underwent recording under during the MRI scan. The method uses the EEG data as the task regressor and then infer hemodynamic change in response to electrical event such as the intellectual spike. And also, it believed that the ratio of the maximal ball response represent about the spike onset zone, which may be turned to be the marker of the seizure onset zone. This example of the spike that detect from the patient with the heterotopia, and then its location to also show on the ball imaging. So very close to the area that's identified that this heterotopia may be the marker of the epileptic focus. Also, the task-based MRI scan and fMRI scan paradigm have been increasingly been complement with the rating state acquisition, where participants do not perform any specific tasks. So rating state database can be used to map local functional parameters. So example, rating state MRI scan can study about connectivity analysis used to map multiple functional relevant network in single session. For example, like the looking about the network of the visual, sensory, or maybe the default network. In select epileptic cohorts, these two identify atypical functional connectivity in both large-scale network, in which relevant to the seizure generation. The next, my talk is a diffusion weight imaging. This is another also very important neuroimaging. We call the DWI. So use the MI sequences designed to sensitive diffusion of the water molecule in the brain tissue, and can be used to assess about the white matter architecture and microstructure. In the brain, diffusion is restricted by the intracellular and extracellular boundary. So with the myelin being the main barrier. So DWI provide the summary parameters such as the functional anisometry, FA map, and apparent diffusion coefficient, or ADC map, we can, and from the DWI imaging. So this can be used as a study to identify about the white matter tissue and the white matter tract. So analysis of the hippocampus being diffusely, for example, can provide a sensitive measure to health assessment and lateralization of the hippocampal sclerosis as well. DWI can also inform the model that allow visualization and quantitative assessment of the white matter tract in the brain. So diffusion tensor imaging being specific of the DWI, use a mathematical model of the tensor to calculate about diffusion direction in its voxel. So a tensor in DWI describes the strength of the water diffusion in different directions. DGI-based tachography methods have been most commonly used in early stage with the white matter tachography, but are fundamentally limited to that a single tensor can only resolve of the single fiber direction with the imaging voxel, when at least about 90% of the voxel in the brain contain more than one direction of the fiber. This one very nice picture show at the tachography. So higher order models such as the constraint spherical deconvolution can be incorporated to deal with the multiple fiber population in this voxel that we call the cross fiber problem. These models are essential is a white matter pathway need to be identified with the tactographic technique. So even the state-of-the-art technique still face challenging, making the development of the fiber orientation model and diffusion tactography reconstruction technique are still ongoing field of the researches. DBI is not necessary for all patients with epilepsy undergoing for epilepsy surgery evaluation. White matter tactography has the potential to inform about the degree of the functional loss post-surgically, especially when the damage to the key white matter tract is possible. For example, tactography can use to assess about visual loss when its resection can be damaged about the major loop, or maybe visualize of the pyramidal tract could be used for predicting or the presence of the absence of the motor deficit when resection overlap with the motor cortex. The example of the case with we have tuberous sclerosis, so we worry about because heterotopia is close to the occipital cortex, so we do the tactography to guide resection of this lesion and to avoid the visual loss or visual defect after from the post-surgery. My final talk is going to talk with the PET and the SPECT in epilepsy. So PET epilepsy, PET is a non-invasive measurement of the local tissue physiology in human. Interictal FDG PET have been accepted as important tool for physical evaluation. FDG PET can demonstrate area of the reduced glucose metabolism that corresponds to the area of the seizure onset in focal epilepsy. The value of the PET for localization has been firmly established both in the temporal epilepsy and the extratemporal epilepsy. In temporal epilepsy, PET has been important role for the physical evaluation. The hypometabolic chain are usually considered larger than the particle abnormal, particularly in patients with the focal seizure associated with the mesial temporal sclerosis. The hypometabolic lesion is usually diffuse, involve the entire temporal lobe of epileptic site, including about the polar, include the lateral region, and as well as the mesial temporal area. The sensitivity of the FDG PET in temporal epilepsy is reliable localized about 60 to 90%. How about the PET in extratemporal epilepsy? Localization of seizure foci in extratemporal epilepsy present a more difficult task than the temporal epilepsy. Normal FDG PET study are seen frequently, usually in patients with normal MI scan. Furthermore, combined use of PET with other multimodal imaging may be helped to localize value for the patient who exhibit normal MI scan. Location extent of hypometabolic lesion is not necessarily congruent with the location and can be extend about beyond of epileptic lesion. For example, this one has a parietal epilepsy. The extent of hypometabolic extends from the parietal to the neocortical temporal area. How about the PET in the frontal lobe epilepsy? Where the sensitivity of the PET vary from the 45% to 92% of the frontal lobe epilepsy. Hypometabolic concordant with the EG focus is only 32% only with the frontal lobe ictal onset, compared with the 77% of the patient with the temporal epilepsy. The low diagnostic yield of the PET can also be found in the non-lesion frontal lobe epilepsy. Interictal FDG PET occur in the presence of the focal MI scan lesion, but usually include about the area of structural lesion, but often extend beyond about the structural abnormal. For example, like this, the area very extensive more in the frontal area. So remote hypometabolism also can be noticed related to the seizure propagation pathway, which could help indirectly to narrow about the potential region of the seizure onset. How about the PET in parietal epilepsy? It's much more difficult to diagnose due to the variable clinical presentation because the parietal lobe have a variable presentation. Careful history about the aura and summary and careful analysis of the result of many diagnostic methods such as MI scan, EEG, PET, SPECT are mandatory, although no single method can directly localize the seizure onset zone. The low diagnostic yield of the FDG PET on the non-lesion parietal epilepsy. This example of the parietal. How about in occipital epilepsy? Occipital epilepsy, the localization rate can be 40% by MI scan, but 60% by the PET scan. Interictal FDG PET show the hypometabolic lesion concordant with the intracranial electrographic localization in patients with occipital epilepsy have been reported. Focal hypomedullary can be confined to the site of the small occipital cortical abnormal demonstrated on MRI scan, or diffuse hypomedullarism involving the ipsilateral temporal occipital area also could be found. Interictal PET in occipital epilepsy with or without automatism in reported in patient with occipital epilepsy with automatism what the presence of significant glucose hypometric in temporal lobe have been reported. This is an example of the PET scan in occipital epilepsy. How about the SPEC? Is my last talk. SPEC is a functional imaging method that studies the distribution of the regional cerebral blood flow in different brain regions. Therefore, it provides both functional and topographic data. So SPEC is a non-invasive, inexpensive, safe, and practical technique that enables study of the regional blood flow either in the ictal or the ictal condition. This technique advantage have made SPEC more reliable tool in the physical evaluation of the intractable epilepsy. SPEC in epilepsy have been routinely used for ictal study, correct localization about 80 to 90% with the temporal epilepsy. The localization information of SPEC has been limited by several factors. One is the ejection time before the seizure spreading, and positol sweep have been demonstrated that occur about 1 to 2 minutes positively in temporal seizure. The resolution of the SPEC imaging also another obstacle. So you might need crystallization with the SPEC with the MI scan, or maybe do the crystallization with the interictal and ictal to do the subtraction technique to identify the regional blood flow changes. This example of the temporal epilepsy ictal SPEC to show the increased regional blood flow in the temporal area. How about the ictal SPEC in the extratemporal epilepsy? Localization, extratemporal is a major challenge to epileptologists. Because the short duration of the seizure compared with the temporal epilepsy, therefore injection time has to be shorter. Maybe we recommend to be less than, not more than 30 seconds. We get to before to achieve the good ictal SPEC study. Early tester, it provides to get the ictal SPEC with the correct localization in extratemporal epilepsy, and also ictal SPEC can provide variable localizing information in the absence of structural lesion, when invasive are usually required for the next step for physical evaluation. The example with good ictal SPEC in the frontal epilepsy. How about the localization is more in the frontal epilepsy? The seizure origin frontal lobe appear to associate variable ictal changes apparent to the according of the site origin with the frontal lobe. There is kissing evidence showing accuracy of the ictal SPEC for lateralizing and localizing of the ictal onset in frontal epilepsy. Ictal SPEC may reflect about different seizure symptoms from the frontal lobe of the same individual, and that simultaneous EEG during the ictal SPEC tester was very crucial for interpretation of the SPEC. How about the SPEC in the parietal epilepsy? It's been proved at the great value in localizing a parietal seizure. Ictal SPEC show the focal hyperperfusion correspond with the structural lesion. Two clinical patterns have been recognized associated with the pattern of perfusion in the ictal SPEC in the parietal epilepsy. One is sensory motor manifestation, usually characterized with the hyperperfusion in the anterior parietal area. Psychoparetic type associated with the posterior parietal hyperperfusion demonstrated on the ictal SPEC. So this pattern may be reflected about propagation of epileptic activity via the interconnecting fiber. Lastly, ictal SPEC in the occipital epilepsy. Ictal SPEC studies show relative low diagnostic yield in extratemporal epilepsy, but it can be used as subgene lateralizing in the about 76% correct localization, and only possible in about 29%. To achieve a good localization in ictal SPEC in occipital epilepsy, the tester has to be injected less than 30 seconds and can be provided novel localizing data in MRI negative occipital lobe. That is the final of my talk. Thank you very much for your attention. Thank you very much.